Welcome to our webinar on compassion and primary healthcare. Today's webinar is jointly convened by the World Health Organization Special Program on Primary Healthcare and the focus area for compassion and ethics at the Task Force for Global Health. My name is David Addis, and I'm delighted to welcome you. Compassion can be considered as a bedrock of primary healthcare. Compassion not only motivates the primary healthcare or PHC workforce, it also can be the engine that reorients health systems to primary healthcare. As with other aspects of global health, however, the role of compassion in primary healthcare is often assumed or implicit. Today's webinar represents an effort to explore this link and make it explicit. We'll open with reflections by Dr. Shams Syed, followed by a brief presentation by Ashley Graham on how compassion is linked to the core principles and operations of PHC. We'll then hear from leaders in primary healthcare, followed by discussion. We invite your comments in the chat, and we look forward to your questions. We intend this webinar to be an open space for exploration and for challenge that will help us refine our thinking and our compassionate action. I'd like now to introduce my friend and colleague, Dr. Shams Syed, Head of Policy and Partnerships at the WHO Special Program on Primary Healthcare. Over to you, Shams.
Thank you so much, David, and greetings to all colleagues across the world. It's a real privilege to be part of this exploration. And as David has highlighted, it's an exciting moment to explore together the linkages which we believe are profound between compassion and primary healthcare. Today, as David has highlighted, we will be exploring this with you, and we come at this webinar with that open spirit of exploration. We also come at it with humility in order to understand compassion as it pertains to primary healthcare. As David has mentioned, we will have a few key points being put forward at the start of this webinar in order for us to get a compass for our discussions. And then we will be joined by an illustrious panel of 4 colleagues who I think you'll be very pleased to hear from. I'll introduce those colleagues in due course. And importantly, we have kept a good chunk of this webinar for facilitated discussion. So you'll see a Q&A box, which if you could kindly place your questions and actually even your reflections, because we are exploring and synthesizing our thinking as we go. If I may have the next slide. Our Director General, Dr. Tedros, has consistently highlighted that we must urgently reorient health systems towards primary healthcare as the foundation of universal health coverage. You have heard this in various guises over the last few years, but you can see that the momentum is now gaining traction. Next slide. The question immediately arises, what is primary healthcare? And I do want to just spend just a couple of minutes to express that the 3 components of primary healthcare as an approach is an important starting point for our discussions. And those 3 words that, if I could ask for the next pieces there, multisectorality, empowerment, and services. These 3 components of primary healthcare constitute the primary health care approach. So what do we mean by that? Multisectorality, the basis upon which health is produced, is often outside ministries of health. This is the bringing together of various sectors to enhance health and well-being of a population. The focus on empowerment, people and communities as the core of primary healthcare as an approach. And importantly, of course, the services, the integrated health services, of course, with an emphasis on primary care as a first point of contact, linked and integrated with public health functions. So these three components constitute the primary healthcare approach, and it's important for us to set that as a point of departure in this discussion. Next slide. It's also important to understand that we are, of course, about achieving results on primary healthcare. And WHO and UNICEF, through the release of an operational framework, have clearly articulated 14 interdependent levers for action, 4 of which are strategic, 10 of which are operational. All of those are interdependent. So it's not one in favor of another, it's actually bringing together those strategic levers that focus in on political commitment, governance, financing, and engagement of communities, and operational levers that focus in on various aspects of a primary healthcare driven approach to health system strengthening. Models of care, workforce, physical infrastructure, medicines, the list goes on. Of course, something that's dear to my heart is systems for improving the quality of care. All of these interdependent levers focus in on the results that will be achieved through action using those entry points. Next slide, please. But let's turn to what David was introducing. What might be the engine behind those levers and those 3 components? And we believe that this could be very much related to compassion. As many of you are aware, we have been exploring the role of compassion over the last few years in various issues related to quality of care. But if you can see that this compassion equation that we like to use that term, the awareness, the cognitive awareness of suffering, the empathy, the emotional resonance with the suffering person, but importantly, not leaving it at that, focusing in on the action, a commitment to alleviate suffering. So our webinar today is really to unpack that further. We have worked with our dear colleagues at the focus area of compassion and ethics to think through the linkages between this 3-pronged compassion equation and primary healthcare, both in terms of the 3 components as well as the levers that I outlined. So with that, if I may, I turn to my colleague and friend, Ashley Graham, to take us through some of the exploration that we have done.
Many thanks, Shams. Next slide, please, Amy. So it's my pleasure to speak on behalf of our program, the Focus Area for Compassion and Ethics, to begin our exploration of the relationship between compassion and PHC. And as Shams mentioned, compassion might be the engine that propels this radical reorientation of health systems toward PHC. So I'm here to further address the question, why compassion? Compassion is the motivation to reduce suffering that arises from a deep experience of shared humanity and solidarity. It takes many forms. It might be expressed as the provision of quality care through some sort of technical intervention, or simply accompanying someone through suffering and painful loss, simply holding their hand. Compassion can be cultivated. It can be harnessed and channeled in service of social justice, health equity, and human dignity. It is the bedrock of caring professions, and when infused throughout health systems in a way that is attentive to context, compassion actually helps create sustainable healing environments. Next slide, Amy. So if we make the linkages between compassion and PHC explicit, we can see how compassion might be the engine that Shams described. First, PHC is a whole of society approach, and compassion enables us to see that whole society, whole community, whole person, whole health system. Like compassion, the PHC approach has solidarity and social justice at its heart. Compassion can provide the glue that ensures these values remain at the forefront of considerations and decisions at all levels of the health system. And a compassion-infused primary healthcare can promote flourishing of patients, providers, families, communities, and health systems. Next slide. Unless the central importance of compassion is articulated and intentionally realized in day-to-day practice, it loses the power to support well-being of patients, providers, and health systems. Decisions without compassion might become bureaucratic, impersonal, or even insensitive. Not only does compassion implicitly motivate PHC workforce in their day-to-day work, it also is explicitly embedded in the 2018 Declaration of Astana. You can see it here, that it's about high quality, safe, comprehensive, among other things, care provided with compassion, respect, and dignity. So how might we be more explicit about the centrality of compassion to realize it as an engine for this reorientation? Next slide, please. We at FACE spent a great deal of time combing through the literature and engaging in an iterative process to draft claims for the relationship between compassion and the WHO UNICEF operational framework for PHC. What I'll share now will serve merely as a starting point for our discussion today. So let's explore how compassion relates in specific ways to the 3 components and 14 levers for change within the framework. Next slide. The 3 components of PHC each have strong linkages with compassion. They're interrelated and they provide the overall thrust for the PHC strategic and operational levers that I'll cover now. The integrated health services with compassion are designed and delivered to address the needs of the whole person. Empowered people and communities. Compassion fosters that empowerment and also promotes well-being through understanding and connection. Multisectoral policy and action. Compassion demands collaboration across sectors and urges collective work with a focus on the determinants of health. Next slide, please. The 4 core strategic levers to achieve the PHC vision are shown here. Political commitment and leadership. With compassion, it fuels political commitment that's required to develop, implement, and sustain systemic change. Governance and policy frameworks with compassion drive action that's geared toward alleviating suffering through the PHC approach. Funding allocation of resources. Compassion ensures that those resources are allocated with an emphasis on equity and minimizing financial hardship. And finally, engagement of communities and other stakeholders. Compassion invites listening, understanding, and co-development, and leads to priority setting that promotes equity and collaboration. Next slide, please. The operational levers bring the PHC approach to the everyday realities of health systems. They are, as with the strategic levers I covered just a moment ago, deeply interrelated and synergistic, and they are dependent on human connection and relationship. You can see them here, models of care that are continuous, comprehensive, coordinated, and people-centered. Compassion within a PHC workforce supports the day-to-day expression of that compassion. There's an opportunity for interprofessional training. Physical infrastructure allows us to focus on how people are affected to improve wash, power supply, transport, and other infrastructural factors. I won't read them all here. You can see them for yourselves, but you can get a sense of how compassion humanizes, as with digital technologies for health, for example, ensures human-centeredness, is essential for improving quality, prioritizes those elements that are of the greatest importance to the patients and communities in the areas in which we're working. And in terms of monitoring and evaluation, it allows us to monitor experiences, evaluating the alleviation of suffering, which requires new compassion-focused metrics. As you see, the 10 levers here address specific key areas in which compassion can be used as an engine for change. Next slide. So beyond those strategic linkages, there are 2 other dimensions we explored that are worth noting. First, the literature on compassion in healthcare highlights the importance of safe, emotional, and social spaces in which caring relationships can flourish. And this dimension is alluded to, but perhaps not fully explored or fully realized within 2 of the levers I mentioned. For example, models of care and physical infrastructure, creating that enabling environment, if you will. And second, and perhaps more fundamentally, neither the overall framework nor the individual levers fully identifies compassion as that essence or driving force. For compassion to reclaim its centrality within PHC, attention to each of these components and the levers that I've outlined here will be essential. And also essential is the intentional cultivation of the relational dimensions of compassion at every level. Next slide. Now, before I turn it back to Shams, I'd like to just spend a moment talking about your perspectives, those perspectives shared by you all who are attending this webinar today, attending and joining us from over 50 countries around the world. Next slide. The first of the 2 polling questions we asked is, how would you describe the relationship between compassion and PHC? And all of you in your learnings that you've shared with us highlighted, for example, that compassion is essential and foundational. It's a core value. It is humanizing and relational, that there are challenges and gaps, some of which hopefully we can address here today. that compassion enhances the experience and outcomes within PHC, and that there's this deep connection to equity. The second, next slide, please, polling and final polling question: how might we more intentionally bring compassion to the heart of PHC? What rose to the top was awareness and education, perhaps through training and engagement. You talked about the importance of relationality, emphasis on dialogue, listening, engagement, as well as transforming cultures and structures to emphasize staff support and models of care, creating those enabling environments that I alluded to. Policies, procedures, and values were also clear in your responses. The importance of institutionalizing compassion through new metrics and measures for accountability and standards. And finally, that connection to quality we've already mentioned, that compassionate care is quality care. Next slide. Shams, I'll invite you to return and I'll turn it back to you.
Thank you so much, Ashley, for taking us through that. And in the first phase of this webinar, we wanted to make sure that we started with that frame of reference and with appreciation to the FACE team for all of the efforts in doing that work. Now we'll turn to our panelists. And what I'd like to suggest is that I'll introduce all the panelists in one. They have long histories that I'll go through in one hit, and then we'll start with their reflections. So we have 4 panelists, and you'll enjoy listening to each of them. The first panelist to introduce is Ms. Venus Dadirai Mushinanga, and she's a public health consultant and pharmacist and has held leadership positions on boards of directors in professional associations and through executive management roles. And importantly, she has pioneered the setup of cancer health services in Zimbabwe, and she worked in the Ministry of Health and Childcare, coordinated the integration of palliative care services in the public health sector, cancer programs, the WHO PEN project for NCDs, COVID-19 response, amongst others. And her goal is to ensure UHC through compassion-driven, holistic, and patient-centered care models. She is a young leader for the Union of International Cancer Control, and of course, brings a clear and long history of experience. Dr. Shaili Prasad, who will also be sharing his thoughts, is the Executive Director at the Center for Global Health and Social Responsibility at the University of Minnesota. And he is the Associate Vice President for Global and Rural Health in the Carlson Chair of Global Health, the Executive Director. So, and Professor and Vice Chair of the Education at the Department of Family Medicine and Community Health at the University of Minnesota. Dr. Prasad has worked in underserved areas, including rural areas, for 3 decades as a clinician, has conducted health services research, and has been engaged in education across disciplines. And he has also been involved in academic department strengthening and mentorship training across various universities across the world. The third of our 4 panelists is Dr. Samba Wembo, who is from Chad and is a UN physician and UK Med Emergency Doc. He has an MD from the University of Jamaica and 2 Masters of Vaccinology and Tropical Medicine from the University of Bordeaux. Currently, he is also working on another Masters of Sexual and Reproductive Health, Policy and Programming, and he specializes in emergency medicine, sexual and reproductive health, and family planning and rights. He has 16 years of experience in primary healthcare and public health policy and management, working as Chief Medical Officer of health districts within the Ministry of Public Health in Chad, and as a physician and medical coordinator within UN and INGO humanitarian areas. He is a Fulbright Humphrey Fellow with the CDC Division of Global Reproductive Health. The fourth of our 4 panelists, a dear friend and colleague, Dr. Anbarasi Edward, who is from the Johns Hopkins University and is a full-time faculty at the Department of International Health at Johns Hopkins University, a member of the Centers for Humanitarian Health and Global Health. She has decades of experience conducting health systems research, training, and evaluation, focusing in on quality of care, community-oriented research in LMICs for national ministries, the World Bank, the WHO, FCDO, PAHO, and other USAID-supported agencies, including a wide range of initiatives. She currently teaches the quality management and project management courses and co-directs the MPH Health Leadership Management concentration at Hopkins. If I may take this moment just also to highlight that she co-instructed one of the most important courses at Johns Hopkins that I had the privilege of being part of a couple of decades ago with Professor Carl Taylor, the late Professor Carl Taylor, who was instrumental in the primary healthcare movement back in Alma-Ata. With that, if I may, let's turn to Dr. Anne Barassi-Edwards to kick us off. Dr. Anne Barassi.
Thanks very much, Shams, for that gracious and benevolent introduction. I'm very delighted to participate in this webinar with very distinguished colleagues, as in my perspective, compassion is the missing ingredient in organizational change management. Next slide, please. We have the evidence on the metrics of compassion, the scoping reviews from 2016 and 2018, the work by Libreta Flores and her team on building compassionate communities with social accountability mechanisms, shifting the focus from organization and health system to a wider shared responsibility with families, neighbors, and communities, schools, and places of worship. Though implementation has been mostly in high-income countries and Latin American countries, Canada and Australia, the primary focus has been on palliative care. Susan Frampton and her colleagues report on the experience of Plaintree to drive the adoption of patient-centered care principles and practices, integrating the values of compassionate human interactions. And of course, the recent work by Giorgio and Shams and other colleagues from WHO on health workforce governance for compassion and respectful care. However, of the 20 country examples they reviewed, only one had moderate certainty of evidence. The other 19 had low or very low certainty. Next slide, please. Most of these publications are from high-income economies, but many of us in this webinar are cognizant of the healthcare context in low and middle-income countries where providers function in extreme resource-restrained environments, limited compensation and reward mechanisms, unregulated and unstable political environments, unrealistic patient and community expectations, high patient volume and disease burden, and the list goes on. Yet many of them demonstrate remarkable resilience, courage, and dedication. In the conflict region of Mindanao in the Philippines, where kidnappings and abductions were commonplace, with frequent interferences and roadblocks by military convoys, I was fascinated by this remarkable dream team. These health providers exhibited excellent dedication and commitment, sacrificing their personal resources to ensure essential medicines and provide quality care for the poor communities. Their exemplary performance won them the National Award or Center of Vitality for meeting quality standards. What was their motivation? 78% of the patients attributed satisfaction to politeness and kindness of the provider. Next slide, please. During a period of famine and extreme drought, these remarkable community health workers in Kenya provided care, often sacrificing the scarce food resources for neighboring children with severe malnutrition. The care group model in Mozambique, which is now implemented in over 60 countries, has been evidenced to reduce under-5 mortality and achieve universal coverage for child health. But most of the success has been attributed to the care provided by the care groups, who are the community health workers. Next slide, please. Likewise, in a very remote clinic in Punjab in India, this physician provides care to over 3,500 patients every month. But he is very called by his religion to serve very poor communities. Many of the patients remarked that his compassion and care were the reasons they complied to treatment. Next slide, please. In Afghanistan, where we launched facility and community scorecards to enhance quality and performance, we postulated that the high level of patient satisfaction may be due to a courtesy bias and fear of losing services. Next slide, please. However, subsequently, the qualitative studies we conducted nationally showed that communities were highly appreciative of the care provided both by community health workers and the healthcare providers in hospitals and facilities who traveled to very remote clinics, endangering their lives. Next slide, please. The altruistic motivation is often rooted in religious beliefs, as reflected in this publication from Uganda. Patient perception and providers' empathy and compassion correlated highly with positive health outcomes. However, the negative effects of compassion fatigue and burnout are not uncommon in these settings. Next slide, please. The guidance documents created by WHO and FACE are revolutionary, in fact, in how we define, measure, and operationalize compassion integration for patient-centered care. But the act of compassion often requires us to suffer with or be in some ways inconvenienced. Next slide, please. Many hospitals have been named after this parable of the Good Samaritan, which motivates us as individuals and organizations to pursue a higher altruistic goal for patient care. When Harvey Feinberg introduced the deadly sins and virtues of public health to his staff at the Institute of Medicine, he placed empathy with a sense of compassion as one of the virtues. Next slide, please. Likewise, the first recipients of the Malcolm Bridge National Quality Award placed compassion as their first value. Next slide, please. As we build this community of practice, I hope we can meaningfully deliberate the considerations for operationalizing the compassion framework and metrics for contextual application, especially the third element of action. It's not just awareness and empathy, but how do we act? Next slide, please. And finally, in the words of the father of healthcare quality, our compassion is driven by love. Last week, one of my students in the quality management course, a nurse from Japan, commented that she first experienced awareness and compassionate care visiting the Mother Teresa Sisters of Charity, and it changed her life. And I hope that we in this audience can deliberate how we operationalize the metrics of compassion and the value of compassion to a wider audience. Thank you very much.
Marasi, thank you so much for taking us and whizzing us through some of the academic side, but also the experiential side, and also some of the philosophy behind compassion. So if, without any further ado, let's get through these reflections, because they're all going to be giving us the ingredients for our soup. So Sambo, over to you, please, sir. Sambo, can you hear us?
Yes.
Please, the floor is yours.
Thank you so much. I'm going to share with you field experience and practice from Africa, and finally present a little bit about the perspective we can put in place for enhancing compassionate health, primary health care. According to WHO definition, patient-centered care is providing care that is respectful of and responsive to individual patient preference, needs, and values, and ensuring that patient values guide all clinical decisions. Care, compassion, respect have always been enriched in the value statement of the health profession. Compassionate care has some dimensions including ethical, professional, effective communication, human, spiritual, religious, and getting involved with passion. There are the 6 components of a professional healthcare provider. Next slide. Slide, please. Next slide, please. Can you hear me?
Yes, Sambo, we can hear you and we can see the
Okay.
slide as well. Yes.
Some promoting lifestyles and experience. In Chad, we have some faith-based health organization. Please go back. Please go back. You have jumped over the slide. Please go back. Okay, presenting.
Sambo, I think
Yeah.
there's a slight lag between the advance and you. We are now on promoting practices and experiences.
Yes, yes.
Please.
But I can't see it here.
Yes, everybody else can. I'm so sorry, Sambo, but it's the promoting practices and experiences. Can you see it now?
Not yet. Continue. Yeah, thank you so much.
Yes.
Yeah. So some examples from Chad. We have some faith-based health organizations like Baptist Hospital of Kumra, Evangelical Hospital of Koyong and Development, and some Catholic health facilities. Yeah, in the southern or central or northern part of the country. You know, in Africa and internationally, we have some faith-based organizations like World Vision International, Catholic Aid, Islamic Relief, MEDER, Medical Team International, Samaritan Hope, World Relief, that are working in humanitarian and development sectors. Compassion is in healthcare. You know, it is supporting and having empathy, delivering respectful healthcare during labor and childbirth, caring and having some competence that are the basis of nursing. The drivers and facilitators are in Africa are the long and practical training of medical evangelists. Yeah, based concerning the example of faith-based organization. And why? Because they have their mission, their values, and the humanitarian principles standard that are safe care, do no harm, care delivery with equity, ethics, accountability, etc. Care sometimes or cheaper, sometimes free. They have psychosocial assistance, food assistance, prayer, devotion of medical teams, evangelization of patients and families, support for families, passion in the care process, access, care follow-up, and continued use of the health care. Compassionate care leads to an increase in the passion for recovery, accountability, control over their own health, their satisfaction, safer care, happiness, and also resilience of healthcare professionals, which results in saving the time and cost of care. Next slide, please. Next slide, please. Yeah, some patient testimonials. The doctor came in, pulled up, and shared and said he wanted to talk, and we talked on my terms. The nurse finally came and said, "What do you need?" And I told her I needed to get to the vessel, and I need her to make the BP stop. And it was like I was really pushing her out. The therapist came in, and I hadn't eaten since my surgery, and I asked for a dinner because I was nauseous, and she dismissed my request as if I wasn't important. So I threw up and I got all over my hair, and even though it was different for me, she didn't even wash me. So, you know, there are some patient testimonials about good care or not good care. Thank you. Let's move to the next slide. Next slide, please. Can you hear me?
Yes, Sambo, we can hear you. You're on the conclusion slide.
Yes. Yeah, as all panelists said, and we have presented, there is a limited understanding of compassion respect, and caring behaviors of the health professional providing health services in Africa. Good practice and experience from some faith-based health organizations on which we can draw inspiration to strengthen the integration and promotion of compassionate primary healthcare, potential pathway forward in placing compassionate health primary healthcare as the driving efforts, especially in Southern Africa. Integrate, strengthen, and promote compassionate primary healthcare in the initial and continuing training of health professionals, medical NGOs, civil society organizations, community health workers, or drivers for the achievement of universal health. Yeah, such is the recommendation, the principal recommendation concerning my presentation. Thank you so much.
Thank you very much for sharing those thoughts, Zambo, and particularly some of those powerful patient testimonials, and also getting us a bit of the experience from Chad. And thank you for bringing that to us all. Without any further ado, let's switch now to Venus. Venus, over to you.
All right. Good evening, everyone. Good morning. Good afternoon. Yes, I'm going. Thank you so much for having me today. I'm just going to talk briefly from my experiences working in the primary health care in terms of compassion from the perspective of the healthcare worker, from the palliative care I've done, and also the access to essential medicines. Next slide, please. All right. So I realized from experience and also from a bit of some literature search that unmet healthcare worker needs do impede compassionate healthcare. So it's if you look at the implementation of compassion, the healthcare worker giving the care has to be in the right state of mind to be able to provide this compassion. So, and also the healthcare worker looks at compassion from their perspective, where they view compassion as a virtuous and intentional response to know a person, to discern their needs, and ameliorate their suffering through relation, understanding, and action. But in trying to meet this definition, there are, of course, disablers that people meet their challenges. So you're looking, for example, with the COVID-19 pandemic, with a lot of mental health issues, there was actually a focus on how the environment was affecting the work the workers needed to do, mostly fueled by the stressful environment where as a healthcare worker, your calling is to save lives, and you're having people dying in your care every other moment. So that brought also a lot of stress, and also the issue of the containment measures where you've got loneliness, where we had loneliness setting in. If a healthcare worker was COVID-19 positive, then they were put in isolation. And then also the other issue being insufficient resources, where that frustration sets in, where there is a client before a healthcare worker, and what is the expertise is there, but there is the link with the resources is not there. Then the other issue being the high workload, fueled also, of course, by the staff shortages, and of course, all these are leading into burnout. So these will take away that environment which fosters compassion. Okay. Sorry, next slide. So in terms of, as mentioned in the definition of compassion, and also in the definition I've just given from the health worker perspective, it talks about the relationship side, because that's a key aspect of being able to give compassion. You need to connect with the person you want to give care. So we're looking at issues of communication being there, the empathy, the trust, that resilience to be able to be faced with a situation where you can bounce back from challenges that you are faced every day in providing the care. And also that gratitude, the appreciation that is exhibited maybe by the patient to the healthcare worker, or the health worker to the patient in some instances. Because obviously, if you are having to deal with a patient who's compliant, it is in order, if you practice compassion, to be grateful for them cooperating and assisting you to deliver the care they need. So next slide, please. All right, and then fine, compassion is something which everyone does every day, but then we tend not to have it as an indicator in most of the indicators that we track. So it's something very difficult to say, can we measure empathy? Can we measure trust? Whose perspective do we use to measure that? So it's very complex to measure. So there are various perspectives that are used to measure compassion. There are tools that have been developed with different matrices. But what is critical, what I've highlighted, what I want to highlight today is the easier one, which is the measurement of mistreatment. I think from the examples given by Sambo, he's given that example of that patient who was mistreated, was not given what he'd asked for. So those ones are very easy to measure because that's what maybe human nature will focus on. So there are tools that have been developed to measure mistreatment, which usually would culminate from the failure of the healthcare worker to be able to offer the services in a compassionate way. So they will measure the physical abuse, verbal abuse, emotional abuse, even the neglect. So it is measurable in using those matrices that are available, and it makes it easy for us to be able to then be able to use compassion to actually look at improving the quality of care we provide. All right, then I'm coming to the issue of palliative care. I think as mentioned in the introduction, I was involved in the integration of palliative care in the healthcare system in Zimbabwe. So whilst doing this work, then the realization was that this kind of work is a patient-centered approach, which is very fundamental when we, in my opinion, when we want to practice compassion. Because if whatever we do is not centered on making sure the patient is comfortable and they get the need they want, we don't even care what the outcomes are, because we become sort of like mechanical. We just have to do the processes. But if there's compassion, then we're going to look at all the other things that matter. Like if, for example, in palliative care, is the patient in pain? Are we reaching the desired goals in terms of care? Are they comfortable? How are the family taking it? Are we managing the symptoms? Is there a psychosocial aspect taken care of? I think it's very clear from the previous presentations that the spirituality plays a critical role in compassion. But in palliative care, we're also going to look at the physical, emotional, and psychological well-being of the patient, and the main goal being to alleviate suffering, which is good. So, and then this slide, I was trying to look at the issue of compassion being a multisectorial. It's an area where we need a multisectorial approach. So that is the same principle in palliative care. When you look at palliative care, we're looking at the whole person. So when we start introducing these concepts in the way we work, then we look at the whole continuum of care from diagnosis until post-bereavement, and we're looking at all aspects of the patient in managing their condition. So if you notice that, I think it might be too small to see, but you're looking at the whole treatment cascade from diagnosis. We can move on to the next slide, please. So we are looking at the whole cascade of care, and we are involving the health worker, the caregiver, the patient, and their families. So we are already having that relationship side of compassion being integrated into how we're doing our work. Because the health worker, the caregiver, and the patient and their families have to interact, they have to resonate, they have to want the same goal for the patient, and they have to work towards the same goal. So I think palliative care used to just be looking at hospice care and bereavement, but now when we were introducing it, the model that's there now is looking at it from the point of diagnosis, post bereavement, and after the death of the patient. Next slide, please. All right. So then, also in all the care we provide, there is need for that access of medicines. I think Ambras spoke to the issue of adherence. There was a study, I think, that showed that the patients who were treated compassionately by the doctor who was serving his community actually have more adherence. So that's the perspective of the patient, to say, you care for me, so I'll care for myself. So it's easier for the patient to then have that self-care in them, and it automatically improves their quality of life, reduces their suffering, and also increases productivity from the perspective of the patient and the healthcare worker, because you're not constantly dealing with complications from patients who are not accessing their treatment. I just want to bring out one, there was, when I was a district pharmacist in one of the districts in Zimbabwe, focusing on supply chain management, our provincial pharmacist, Mr. Machingauta, he always used to quote this every training. You'd know if you leave a training without this, that the training was not complete. So he would always say, communicating to a critically ill patient that an essential life-saving medicine is out of stock is like issuing out a death penalty. A real pharmacist does all they can within their power to ensure that the communities they serve have access to essential medicines. So I think from this, that's where I personally developed that lens to say, in everything we do, in every aspect we do in the primary healthcare setting, in providing primary healthcare, we need to look at that perspective of providing compassion, putting ourselves in the shoes of the patient, and also making sure they have access to the technologies they need, including medicines. Next slide, please. Yes, I think that was my next slide. I think as a closing remark, I'll just say, for compassion, it's cross-cutting aspect of healthcare, and it is what drives. It's like the engine for the healthcare system, and it should drive how everyone works in the healthcare sector. That passion for compassion can change the way care is delivered at whatever level of healthcare. Thank you.
Ines, thank you so much for taking us through a host of issues, but also ending with that very strong note on passion for compassion. The points on palliative care, the points related to a health worker's perspective on compassion, and of course, the essential nature of medicines and the linkage with compassion, all well noted. Now let's turn to our fourth panelist of four. So we'll look for questions and answers. So please use this moment to just maybe think of your questions. But first of all, let's turn to my dear colleague and friend, Shaili. Over to you.
Thank you, Shams. Really appreciate this opportunity. To begin with, it's indeed a privilege to be part of this discussion. And I'd like to reflect back on a few important things that have already been mentioned. Number one, that primary health care being an essential foundational need to achieve universal health coverage. That is a huge step in recognizing that we have not been doing things right. The reason I'm mentioning this, let's step back a second and say, what is the purpose of healthcare? Well, we would easily define it as a way to alleviate disease and suffering. But have we done that? Over the past many decades, we have achieved remarkable, absolutely fantastic scientific discoveries, and we have tackled a lot of problems. And we don't have to name all of them today, but we have tackled a lot, to the extent that we become experts in disease care. We've not become really adept at the healthcare aspect of it. So let's step back one step as a community and look at how the healthcare industry has responded to some of the challenges we are facing. COVID is one. The ongoing challenges with various non-communicable diseases is another one. Are we able to, in a way, respond to them to alleviate all the disease and suffering there is? And fundamentally in this discussion, one thing that is lacking is the premise of coverage for a lot of people, and coverage from the primary viewpoint, primary also denoting an essential feature that is needed. I'm thrilled, particularly because I'm a primary care practitioner, that this discussion is finally coming to the forefront, right? The part that is important for me to understand in this context is what are those tenets of primary care that is important to consider? What is primary care? In simplistic terms, it is the premise of being there at the interface of an individual and the health system. Work by Barbara Starfield and others would talk about the essential tenets of primary care. But being there at that interface conjures up a feeling of being connected to people. When I talk to learners of primary care here, I use the term that our superpower is continuity. A superpower is a premise that we are in ongoing relationships with the people that we interact with. Even if we are seeing them for a brief encounter, that brief encounter is a part of a longitudinal series of encounters that helps us understand the person across, helps them understand us, and together we formulate an effective engagement with the healthcare system. And my fellow distinguished panelists have already discussed why that is important and how that has been reflected in overall quality of care. This aspect of it, the relational aspect of it, is the essential part of primary care. And in that relationship aspect is the understanding that compassion is what drives it. Dr. Edwards did talk about some of the examples from around the world. One thing that struck me in a lot of those examples is that it came from a very strongly religious background, many of them, not all, very strongly evangelical background. And those are good lessons for us to learn. Are we doing that effectively in other secular, non-religious encounters too? Because world over, a lot of the healthcare delivery systems are not based on religious entities. Religious entities have a huge role to play in that. So how can we then take elements of that aspect of it in creating the social and emotional vulnerable space, as has been mentioned before, in getting to understand where we fit in the life of our patients and where they can trust in the work that we do. Today, as we reflect on all the mechanisms of healthcare delivery, one of the things that strikes us all is the premise that the trust that communities have on healthcare is at an all-time low. There's a distrust of established healthcare organizations or research institutes and governments. And there are various factors in this, absolutely. We are in a highly polarized society. But one part I'd like to remind us all is that in some ways we have failed. We have failed in making sure that communities continue to trust us, that we are worthy of that trust. And I would make a strong case here that to be worthy of the trust, we need to develop that trusting relationship. Recognize what a privilege it is for us as healthcare providers to be with individuals and communities, sometimes at their most vulnerable states, but understand that as a way of building that longitudinal relationships where manifestation of compassion leads to ongoing work together and a long-term relationship that is integral in both an individual's health, and I would make a case, health of the healthcare system itself. A couple of other points for us to keep in mind. Over the past few decades, particularly over the last 3 decades, we've had a growth in the quality movement in healthcare. And don't get me wrong, it's very important to have quality in understanding what we deliver. I would challenge us to look at that a little more closely, though, because what happens in the quality movements is the things that get measured, and the burden of that measurement is such that the things are more difficult, to measure. Like Professor Hovis commented in the Q&A section, compassion is a little more difficult to measure. Those things get left behind. So as we're measuring quality, it's important to keep in mind that the dry metrics that sometimes get a lot of importance. My mentor in health services research used to say that in God we trust, everybody else brings me data. That is important to keep in mind. But beyond that, what are the unmeasurable ones that we're forgetting? And I would make a case that it is important for us as researchers, practitioners in the healthcare space to give due acknowledgement of aspects of this relationship, aspects of compassion, in ensuring that the quality of care is in a way reflected in acceptance of communities and individuals of the healthcare system. A last part I want to bring up here is an epidemic of burnout, if I can use it in those words, of healthcare providers around the world. Obviously, some of it is based on systems. I saw a comment about what happens in LMIC places where there's not enough of a primary healthcare. There's a workforce shortage. And there's workforce shortage. We are talking about workforce shortage in our state here in the US. And around the world, this workforce shortage leads to us pushing ourselves to the limit while forgetting what is it that brought us to this place. Quite often, when we are overstretched in terms of the care delivery models, we revert to our technical expertise, the expertise that has been taught to us through our institutions of higher learning. For physicians, it might be a particular skill, a diagnostic approach, a lab test, a surgical tool. And again, I'm not here to say those are not important. Those are very important. But then we forget the meaning of why we are there. So I'm here to say that the premise of compassion is not only to recognize where patients benefit from healthcare systems. The premise of compassion is to recognize that that is what gives relevance to the work we do as healthcare providers. And when we reflect on the relevance of the work we do as healthcare providers, we recognize the joy at work. One of my favorite statements is that it's not the work that gets people, it's the angst about the work. I used to reflect on one of my postgraduate students. When she was stressed, she used to go out for a run, and I would always reflect on her. I thought you were stressed. You're putting more stress on your body. And she would say, no, it actually relieves a lot of stress when I'm doing the running. So it's not the physical work that gets people. It's the angst, the premise that what I'm doing is not meaningful to me. So in this conversation about the compassion and relationship building that one has with individuals and communities, it's very important to reflect on how that can feed one's soul. That can be the engine that keeps one connected to the work that they're doing, to understand that their work is meaningful, right? So as we are talking about the importance of compassion for patients and communities and nations in delivery of care, we have to recognize that as an important engine for us too. In all of this, in the premise of measuring the role of compassion, I would ask us all, and Venus did this wonderfully in reflecting on palliative care, the paradigm of understanding a good death. If you look at death as a metric, it's a crude number. So many people died. But if you look at the premise of a good death, one understands that you are in the journey with that person who is dying to ensure they're at peace, that they're relieved of suffering, physical, psychological, spiritual suffering in the process of death. And after all, if we are not here to understand that human condition, then we are not delivering care. So I would make a case that a paradigm of understanding the good death is a way of looking at the difference between pure metrics-driven care to a relationship-oriented, compassion-based, effective primary care as a foundation of universal health care. Thank you.
Thank you so much for bringing all of those perspectives and really bringing us back to that whole concept of being there, which was something that you emphasized and re-emphasized throughout. And particularly this point about measurement will, I'm sure, continue to come up. And it's an important one because, as colleagues have been saying in the chat as well, sometimes we shy away from things that are difficult to do or difficult to measure. And you've highlighted that very beautifully, and also brought together some of those points around trustworthiness and trust. So as we've said right from the beginning, we wanted to keep a good chunk of time to be able to have a discussion within the panel, and we have that time. We'd like to start with one question, which is a burning question that's been placed, and it's an important one. In the hard settings that we're working in, low-income country settings, perhaps settings of fragility, conflict, vulnerability, just imagine that PHC is not well established or functioning for that matter. It's so hard to find compassion in those situations. We're very blessed in this panel to have 4 panelists who have direct experiences from those very difficult situations. When it's so hard to find compassion, what's your advice as experts in this field? What is the first move that you can make within that environment? And perhaps we'll start in the same sequence, starting with Anbrasi for your thoughts and then moving to Sambo, Venus, and Shai.
Thanks very much, Shams. I think having worked in conflict and post-conflict situations where primary healthcare infrastructure is either lacking or fragmented or completely non-existent, we try to look for the existing providers. These may be traditional healers, they may be pastors, they may be congregations, mullahs. So who is providing care? Who is taking care of the sick? You start with them. So looking at the communities, whether these are traditional birth attendants, it may not be primary health care. Who is feeding the poor, ministering to the sick? So you begin with that existing community infrastructure. Who are the stakeholders? And to do that kind of an exercise is to work with communities using formative research approaches to find out who they trust, which is what Dr. Prasad talked about. So who do they trust? Who do they go to when they have trouble, when they have needs? And you always find these leaders and champions in the community. So we would start there and then slowly begin to work with them, build their trust, and engage them as partners before we actually build a functional primary healthcare system.
Thank you, Anbrasi, for that. Sambo, please do continue, and coming to Venus after Sambo.
Yeah, from my experience working in humanitarian areas, from faith-based organizations, I think it's the same example. Working with local communities, local NGOs and community health workers is the best way of delivering compassionate healthcare. We do use to train people and to enhance their capacities, because in Africa, particularly, people have compassion. People know how to be compassionate for patients or part of the families, patient or part of the communities. And so we, from the experience from a faith-based organization, we deliver loving care. We deliver care with solidarity. We are focalized you are centralized in community and individual needs. So we transfer these competencies to the community health workers, to the non-governmental organization, and basically we choose faith-based organizations, local organizations that have sound experience in the domain, and we work for them because we know we have a heavy load. So we have to respond to different kinds of conflicts that are very volatile in hardships. But by transferring the sustainability of the compassionate primary health care, it's possible to enhance the local communities' capability to continue doing so when we have exit project.
Thank you, Sambo. Thank you so much. Venus, first move.
Yes, I think for compassion, I think you'd go to relationships. The first thing is to identify where the linkages are between the community and the service provider, looking at a bottom-up approach. Because what I've noted is in the most remote areas, the healthcare workers and the community, they are so interlinked. They move as one. They are one family. They have concern for each other. So that is the first step to strengthen those relationships, those synergies. That's the magic for me. Thank you.
Thanks, Venus. Shaili.
Thank you. I really appreciate the comments from the other panelists. And it's interesting that this question came from Dr. Hina Javed, who's doing some really amazing things in Pakistan in developing primary healthcare. One framework I would like to propose here, that quite often we look at healthcare delivery as a very organized sector. And it is, don't get me wrong, in many places it is, that we expect that there are hospitals and clinics, and we have gotten to a point of being a little exclusionary, that the care delivery occurs in these spots. I would actually make a case that for effective coverage of healthcare needs from across all aspects of society, we need to go beyond that. So as Sambo mentioned, as Ambrasi mentioned, it's important to look at who are the others who extend the reach of healthcare. We know that in all societies that the demand and expectations of healthcare doesn't have a roof. It can keep increasing. And the supply side of it in terms of the healthcare workers is limited. So how do we then augment the effect that we have as healthcare workers in providing for larger communities? And this is where I think it's important to understand community assets, building relationship with community assets, extenders, and things like that. I would also make a case that going away from the highly individualistic physician-oriented care model to a team-based model where we develop that as a group in delivering care is an integral part of this. And obviously, the models are going to be slightly different in different places, even within a country. You can make a case that a community has its own vibrancy, its own interlinked functionings that we need to understand and work with. This is where I think relationship building should occur both at the individual level, at the family level, and the community level.
Beautiful. Thank you to all of you for just laying out those points. They're all interconnected, but they're all somehow distinct as well. I'd like to turn now to, now that we're warmed up, into the measurement side. And this is going to, it's inevitable that this will come, right? So first, if I may give everybody a chance to think about this, is if there were some key points that you wanted to mention related to the measurement of compassion, particularly as it pertains to the PHC approach, or of any of the different types of areas of intervention, then it would be very useful to hear your thoughts, and maybe we'll go in reverse order. But perhaps I'd like to draw in David Addis into this conversation, because the focus area of compassion and ethics has been actually working on this a bit somewhat. So perhaps we start with David, and then we go reverse order in the panel, starting with Shaili to Venus to Sambo and then to Ambrasi. David.
Thank you, Shams. I saw the panelists smile when you mentioned the word measurement because it's such a challenge for us for the reasons that have already been presented. You know, what gets measured gets done, but these relational aspects, there have been attempts to measure them, and I think we actually are getting better, but the very act of measurement reduces them to checklists that are just become transactional. And so there's something kind of like the Heisenberg uncertainty principle at work here, whereas we try to measure something that is ineffable, we reduce it to a transaction, and the relationality, which has been so highlighted here, becomes lost. Having said that, there are some very good measures of compassion that are being tested in different areas, and we would love to see some of these explored in the primary healthcare setting in areas where those of you who are attending this and your colleagues work. Shane Sinclair and his colleagues at the University of Calgary, including Sandy Rao, have developed a compassion measures toolbox, which is available on the FACE website, and we'll be happy to share that link with you in a moment. There are basically three approaches to measuring compassion. One is asking the actor, the compassion giver, to so to speak, are you compassionate? Of course, well, I'm a compassionate doctor. I mean, and so there's some obvious interpretation bias with that first person perspective. Much more important for us, I think, is asking the patient, the person receiving care, did you receive compassionate care? Were you attended to? Were you respected? And there are some very good second person measures that are available now, but they've been mostly developed and tested in the global north. And so some of the questions may not be relevant. For example, does the concept of warmth, did the provider express warmth to you? Does that translate? So I think we need some very good qualitative research on how do people receiving care in a primary healthcare setting, how do they receive compassion? How do they recognize it? What are the qualities in the providers that communicates to them that they are cared for and that they are the recipient, in a sense, of compassionate care? And then there's a third measure, which is less well done, which focuses on observation and action. You know, did the healthcare provider actually look at the patient? Or were they working on their computer, typing in electronic medical records and never even asked the patient their name or introduced themselves? And these also may be culturally determined. So we have many challenges. I would refer you to this toolbox as a starting point, and we would be very interested in your experience in measuring compassion, because we're really at the very beginning of this adventure. Thank you, Shams.
Thank you, David, for summarizing that so wonderfully. Colleagues, Shaili, big thoughts on measurement. You brought it up in your perspective, so back to you.
I was smiling because I was hoping somebody else would tackle it first. So thank you, David. I really appreciate that. I think you bring some very essential points in what you mentioned, David. Conceptually, I've looked at not just compassion, but in general, I mentioned the premise of the measurable ones getting measured and the others being neglected. I feel that in health services research, in healthcare delivery quality measurements, we have to keep that in mind when we introduce a new measure. What are the unintended consequences? And if I can mention this might have a bearing in this conversation. I was working in a very small rural hospital in Mississippi. And when the measurements came for congestive heart failure measurements, which was a Medicare required measurements here in the US, one of the first programs that was sacrificed there was teenage pregnancy classes. And it bothered me a lot because I hadn't seen good evidence behind measuring CHF. And one might make a case it's not really achieved what it was supposed to achieve. But it was easily measurable because we could measure certain metrics. Whereas a teenage pregnancy class is, what are the outcomes? How do you measure those outcomes? Some of those outcomes might occur, I don't know, 15, 20, a generation away. I feel that this is something to keep in mind as we look at compassion. And I would propose that the premise of compassion should be the background, the all-pervasive background in all activities that we do, rather than an individual disease-specific metric, right? In this, one of the questions that was there in healthcare survey, health provider survey actually, struck me. The question, you folks have probably seen this, it actually came from marketing, and I initially had some very strong negative feelings about this question. But I've been thinking about this question a lot, and the question asked, would you recommend this healthcare provider to your family member? I wish they had asked an add-on question, why? So if I'm coming to see David as my primary care provider, and I have a fantastic interaction with David, and all of us have had fantastic interactions with David, the question for me would be, would I recommend another friend to come and meet David? And the why brings up the point about David really hit on some core points that I felt that he connected with me, right? So I feel questions like that are things that we should explore more. Again, we don't want this to be an exercise in a checkbox. Yes, I'm compassionate. I'm 90% compassionate. The rest of it is all hell units. You know, that is not the way for us to go.
Great thoughts, Shahid. Venus, anything that you wanted to bring in here before turning to Sambo?
Yes, thank you so much. I would look and consider the role of artificial intelligence in simplifying how we measure compassion, because I think the way it has evolved now and is designed, it just combines all these matrices and all the most complex things and comes up with solutions at the click of a button. So I think it's one area which would probably consider to say, how do we develop tools that allow us to measure compassion and give us instant results that we can then look at improving our systems. And also the issue of integrating it in the systems that are already there. Every health survey, we need to define indicators such that everything stops being about indicators, percentages, and all that, but finding the reasons behind those, maybe changing our assessments to be qualitative and quantitative, so that at the end of the day, we actually understand the story behind the numbers that we are chasing. Thank you.
Great point, Venus. And essentially also bringing this back into what Ashley was highlighting in terms of digital technologies for health as being one of the operational levers, the human face of that, clearly articulated, Venus. Sambo, turning to you and then coming to Anbrasi to wrap us up. Sambo, I think you're on mute, my friend.
Okay, thank you. From my experience and observation from the ground, I think measuring compassion in primary healthcare is an ongoing process. It's immediately measured when the patient for whom you are caring and his family are satisfied of the service you are providing them. You know, I have presented some example of a patient testimony. When the patient asks you to help him go into the restaurant and you can serve him, you know, he will be satisfied. And also the family will be satisfied. Because primary care with compassion is patient-centered and family-centered. And as I thought, it is an ongoing process, because if you are caring for a patient living with HIV, a patient living with tuberculosis or with cancer, you know, how well is this patient is receiving the visit of community health worker at home, how well he is coming back for the appointments, for receiving his treatment, how well is the level of satisfaction of the individuals, of the communities, or the population of service you are rendering? How well is the level of acceptation of the service you are rendering, and how well people are coming back to the health facilities you are supporting, or some tools you can use for measuring the quality of compassionate care you are providing. You know, community will come back. They will inform other person that this or that one health service is very reliable, and you will visit a lot of patients in your health facilities. That signifies that you have reliable, sound and compassionate health service. So, for concluding, it is an ongoing process, and it is not ongoing because the patient is now at the hospital, but because he's also outpatient, and it's going until the death and after the death, beyond the death. How well healthcare worker or health professional are going to support families with psychosocial and mental health advice. This is my point of view. Yeah.
Thank you very much, Sambo. Anbrasi, turning to you.
Couple of things based on the reflections. A lot of presentations addressed integration, but I would focus on cascading down and cascading up the drivers of compassion, starting with the organizational culture. Is compassion rewarded? Does the leadership exhibit compassion? Not just the providers and their peers. So the patients exhibiting compassion for the providers. So it has to be something that is interconnected with the system, with the provider, with the patients, with the community, not just the provider to the patient. The second is going back to Albert Einstein's quote that not everything can be counted counts, and not everything that counts can be counted. So the relevance of the metrics we choose for the specific context, just smiling at the patient means a lot to some of the patients and their communities and their family members. The tone of voice that's used. We have seen in many, many contexts where the physician is a demigod. And when he walks in or she walks in, it's like, really walking into the presence of God, and you have to use your these and thous and wait for them. And long waiting times. The touch sometimes is important. When a provider touches you and says, how are you today, or something that connects. But again, cultures are different. So in certain communities, I work a lot, or I was born and raised in Saudi, and in some Islamic communities, it's not appropriate for the physician, if he's a male, to touch a female or smile or use a certain tone of voice. And then in conservative, very conservative communities in India, I found that too. So it really depends on the drivers that the community accepts as appropriate practice for a provider or a healthcare system. And that's why contextually appropriate focus groups or formative research needs to be done before we design these metrics. And then coming down to the whole issue of the metrics. The first Lancet articles that came out in measurement, they showed that 40 to 60% of the time, health providers are engaged in filling out forms and health information systems. And we don't want to create another huge dinosaur of how you measure compassion. We need to look at 2 or 3 metrics that's relevant, that's contextual, that's localized, that patients and providers know how they are measured and how they provide compassionate care, and patients too. We need to create a learning where patients are taught that, this is not concierge service that you expect in a 5-star hotel. There are limitations in the healthcare system, and the providers are doing as much as they can to provide quality care. But I think it's both ways, for the patient to appreciate the provider and the limitations, and for the provider to extend. And it goes to the act and the sacrifice that we go beyond the extra mile.
Thank you so much, Andrasi. Unfortunately, time is just whizzing by, isn't it? But maybe one quick point on this measurement side that I'd like to quickly pick up on is this measuring compassion in its own right, or thinking about this background of compassion in other measures that are spanning the system through a PHC-oriented lens. I've just placed in the chat the WHO UNICEF PHC measurement framework. And while you might not see a compassion measure, what we may think about is how compassion measurement can be embedded within the measurement decisions that are made. So that's something to consider. Now, before handing over to David to wrap us up, I definitely want to turn to each of the panelists for a minute to give us something that they may have learned that they didn't know when they entered into this space, and one thing that you want us to take away from this exploration on compassion and primary healthcare. And if I may, I'll start in the same sequence as we started, with Andrasi, then to Sambo, then to Venus, and then to Shaili. Andrasi.
Creating learning organizations and the humility with which we learn is critical in how we move ahead with this.
Very clearly put, Andrasi, and it's a clarion call for us. Sambo, turning to you and then coming to Venus.
There is a limited knowledge of compassion in primary healthcare. We need to initially train and have continuous training when working in the field. Not only for health professionals, but NGOs and community health. This is the way we can achieve the universal outcome coverage.
Thank you, Sambo. Very clear. Venus, turning to you and then coming to Shaili.
I think we need to balance the negativity and the positivity when we are measuring compassion and we look at the implementation of compassion, because we then tend to skew over the negative aspect of it. So I think that balance is necessary when we do implement interventions in the compassion space. Thank you.
Thank you, Venus. Very clear. Shaili.
Two quick learning points for me. One is the rich literature around measurement is still there, which is fantastic to know. The second is compassion is the soul of the delivery of primary healthcare.
Beautiful. Couldn't have ended more beautifully with the coming back to the soul. I think people will appreciate that. Before handing back to David, I just wanted to mention a couple of things going back right to the beginning of this webinar. Our clarion call is radical reorientation of health systems towards primary healthcare, right? That's the lens within which we enter into this exploration. And what we've been able to do as a starting point today is to really unpack some of those key points of intervention, because as we always highlight, the third component, action, is where the juice lies, and it's sometimes the most difficult part of the compassion equation that we often talk about. So today has been a starting point for exploration. One of the things that we are committed to alongside our colleagues and partners at the focus area of compassion and ethics is to distill, synthesize, challenge colleagues to think further and really be a part of this radical reorientation of health systems towards primary healthcare through a compassionate lens. So it's a profound privilege to have had this opportunity to be with colleagues today. And with that, over to David.
Thank you very much, Sham. And I just want to express my gratitude to the excellent presentations we've heard from the panelists. These have really been stimulating and challenging and inspiring. So thank you very much. And thanks for all of the participants and attendees who've given us such great questions and We've not been able to address them all, but we endeavor to get back to you with some thoughts if we're able to do that. We will be sending a link to the recording, hopefully within a couple of weeks, to everyone who registered. So if you are listening now, you probably registered for this for the webinar, and you will receive a link to the recording, and that will be followed at some point by a report, a written report that synthesizes the conversation, as Shams had just mentioned. So we really appreciate your interest. We're delighted that you joined us today. If I could, just a few summary thoughts. Dr. Prasad summed it up well when he said, compassion is the soul of primary healthcare. I think there's general agreement that compassion is fundamental for primary healthcare, for patients, for communities, and for providers. There's a rich literature on this, and it's our lived experience as well. The aspects of the relational, longitudinal aspect of primary healthcare were also emphasized by several panelists. And I think Dr. Prasad mentioned the being there as showing up is really one of the great strengths of primary healthcare. This relational connection aspect is essential to primary healthcare and to compassion. I think it's also fair to say that primary healthcare operates in some of the most challenging situations and when systems are not adequate to provide the level of care that we would like to. And in these situations, compassion is even more critical, perhaps, than it is in other settings. Venus mentioned that we have a multisectoral systemic approach that sees and attends to the whole person. So compassion is not just an individual quality, it's an attribute of a system that needs to be attended to. For primary healthcare providers, I think it's important to remember what motivated us to enter this field. We are, in a sense, running towards suffering with an effort to alleviate it and to provide nurturing and to promote flourishing. So one's own individual motivation and spirituality, in a sense, is important for keeping that flame alive. At the same time, we need to both remember why we're in this work, but we probably also need to unlearn patterns that we learned in professional school. And Dr. Chaudhry in the chat mentioned this issue of the relationship between provider and patient. And Dr. Edward just emphasized this. We need to unlearn some of the distance and the hierarchy that we pick up in our training. So coming back to a relational dimension, a human relationship, Dr. Gwengo mentioned solidarity. We need to return to this and perhaps unlearn some of what we've learned along the way. Dr. Edward emphasized that in providing primary healthcare, we need to engage others. We need to engage with trusted spiritual leaders. It's not just the primary healthcare worker per se that provides this kind of care. And I would also add that in the great example of the Good Samaritan actually left the man who he was attending to with the innkeeper. He relied not only on himself, but with the innkeeper and others. So we are not alone in this journey. And so I think the challenge is, how do we, both individually and in our community and in our systems, to use Dr. Prasad's word, how can we become worthy of the trust that is needed to provide the care? And this is both an individual responsibility, but it's also a systems responsibility. And we're just on the cusp of starting to understand perhaps how we embed this relationality or maybe re-embed it into primary healthcare and to highlight compassion as the engine for primary healthcare. I'd like to thank all of you for such a wonderful, inspiring webinar today, and look forward to receiving a link from us, and we look forward to engaging with you in future webinars. Thank you so much.